Howdy, good morning, and thanks for learning about MS with me, Boster. It is Sunday morning. My family is still snoozing. My dog and I are up, and I thought, you know what? I'm going to go outside, start a fire in the fireplace, and I'm going to power through some unanswered questions. So if you'd like to join me, whether it be live right now, Sunday morning, or if you're picking up the replay, I hope you enjoy. Let me get that fire lit. All right, so we'll give that a second to get going. And howdy, y'all. This is not a live stream where I'm going to be asking moderators to help out a lot. Hello, Chuck. Thanks for being on the line. I instead am just going to power through a bunch of the questions that have been saved up from previous live streams that I haven't gotten to. So bear with me. And I'm going to see how many I can get through this morning while I enjoy a cup of coffee and fire outside with you guys. So let's start answering some questions about disease-modifying therapies. Again, if you're just joining me, please include where you're logging in from. I love learning where all the members of this growing online village come from. If you have questions, go ahead and leave them in the comments. I very likely won't get to them right now. This live stream, the reason I'm jumping on right now is so I can knock out some questions that have been saved up. So let's do that. First question, Andrew Jones asks, and these are going to be questions about disease-modifying therapies, and I've opened up the folder on pills. So I'm going to answer a bunch of questions about MS pills. And that fire is working out in the background there. All right. So, Andrew Jones asked the first question. Doc, what are your thoughts on Tecfidera? I've been on it since 2014. No new lesions, although I had a very large lesion at C6-7. Thank you for sharing your expertise. Well, Andrew, I think that every drug has knocked it out of the park at least once. And I certainly have patients that have taken Tecfidera since it came out and have done remarkably well. The vast majority, to be honest, have had breakthrough disease, and many of them have escalated or changed to other therapies, but I still have a small group of patients that all these years have made it and have responded beautifully to Tecfidera. So whereas I can't comment for you specifically, I would say more generally speaking, if you're not having breakthrough disease activity, if you're not having new spots on your MRI, if you're not failing the litmus test of life, if your neurological examination is not changing, if you're tolerating Tecfidera and you're comfortable with the safety profile, I wouldn't touch it. I would keep on keeping on. And I'm delighted to hear that you've done so well on Tec after all these years. That's really fantastic. Next question about pills is another question also about Tecfidera. This one comes from Raven Chandra Ann. And by the way, that's a cool name, Raven Chandra Ann. How effective is dimethyl fumarate or Tecfidera? So I think that Tecfidera is a moderate efficacy therapy. I personally don't think that it's as efficacious as the monoclonal antibodies, but I think it's more effective than the shots that are currently available. So for me personally, I place it mid-range. Now, that's a comment that I make in generalities, right? Because every individual, it's either binary. You either respond or you don't respond. Here's a third question about Tecfidera. This one comes from Patty. So M sent it for life. Patty is a great contributor to this channel. She's been a longtime viewer. She also is very active on Twitter. And so she writes in, good morning from sunny South Carolina. What is a good DMT to look for after Tec? Well, Patty, that depends on a host of factors. Did you leave Tec because of GI upset, or because of flushing, or because of low white count, or did you leave Tec because you had breakthrough attacks? And that would change my answer quite considerably. Also, what were you on ahead of time? Had you already been on XYZ drug, or was Tec your first drug? And that would change my answer. So that's one which really depends on context. So the next question comes from Mary Morales. Good morning, Mary. Many of you have seen my I Am Your Father mug. My father gave this to me. He and I love Star Wars, and it's a really cool mug. Thanks, Dad. So Mary Morales writes, my daughter is given her first dose of Jelenia. What do you think about that med? So I think Jelenia is a great medicine. I think that it is mid-range efficacy in the same bucket as Tecfidera. My personal opinion is that Jelenia might be a bit more effective than Tecfidera. That's my own personal thought. I think that it's not as effective as the monoclonal antibodies, the infusions, but I think that it is definitely more effective than the shots. So I think Tecfidera and I think Jelenia are both really solid medium-range pills. Jelenia may have some upsides in that it's once a day and doesn't seem to cause the same GI upset that we sometimes see with Tecfidera. I certainly have used plenty of Jelenia in my day. Now, this next question comes from Stefan, and I believe this was a question that was asked in Friday's live stream. So Stefan asks, can you take another DMT if Mavenclad fails and you have flares? And this is something I addressed on Friday's live stream. The way the American label is written for Mavenclad, you take it the first 2 months, wait a year, the next 2 months, and then you're done with the induction. The American label says you're not allowed to take it for 2 more years. So you can't take another dose in year 2, obviously, but then you're not allowed to redose year 3 or year 4. And if you have breakthrough disease, Mavenclad is now off the table to redose, which leads me kind of like not sure of next steps. So yes, you can start another DMT, but I have questions, personal questions about stacking immunosuppression. So if you've taken Mavenclad, am I allowed to add Limtrada? Am I allowed to add Ocrevus? Is it safe to add Jelenia or Tysabri? And those are answers that I don't yet have. So yes, you can, but I do think that there's a question in my head about stacked immunosuppression. So those are all the questions that I had about pills. I'm going to stick on the topic of disease-modifying therapy. And this time I'm going to talk about shots. So I have 2 questions here. This first one is fantastic. It's from Letitia Johns. So Letitia Johns wrote in and said, dangers of taking Copaxone while pregnant. I just found out I was pregnant unexpectedly and I'm taking 40 milligrams Copaxone 3 times a week. Should I be concerned of any possible birth defects? Well, first of all, Letitia, congratulations. That's awesome. How exciting that you're pregnant. And let me say that if I was to become pregnant unexpectedly on any of the 18 different formulations of MS drugs, Copaxone is the one that I would want to have been on. It is not labeled to be taken during pregnancy. So what I'm saying to you now is off-label, but many MSologists around the country, myself included, actually place patients on Copaxone to attempt conception. We really don't feel, when you look at the registry data, that it's unsafe. And I do not expect to see birth defects or teratogenicity with exposures to Copaxone during attempts at conception. So of all the MS meds you can be on, you happen to have been on the safest one for pregnancy, in my personal opinion. This next question comes from Danielle. I'm not going to say the last name right. Doenges. So Danielle writes in, have any of your patients on interferon developed suicidal depression? And so I recently put out a video just last week, I believe, on MS and suicide. And it's an important, very serious topic. So if you haven't checked out that video, please go to the channel and you can look under my videos. And I just put it out not that long ago. The question is do you have patients on interferon with suicidal depression? And the answer is that interferon can worsen depression. It's possible. It's been documented and studied. And it's my belief that in some patients, interferon can worsen depression. Does that mean that we need to forever avoid them? No. But it means that we need to be very active in looking for depression. And if someone with MS goes on interferon and becomes depressed, I think that we need to be sensitive about that, and we might need to take them off. Have I had patients that had severe depression to the extent that they felt suicidal? I absolutely have. Not unique to the interferon class medicine. The bottom line here, guys, is that people with MS are twice as likely to experience depression. And we have to look for it and we have to treat it. And when we treat depression, one of the things we do is we look for medicines that might be worsening depression, and interferons would be one of those. So that was a great set of questions. I'm now opening up the folder on infusions. And as many of you know, it is my preference to use the most effective medicine that you're comfortable using when I treat your MS. And in 2019, those are typically the monoclonal antibodies. Just checking on the fire. Those are typically the monoclonal antibodies, the infused agents. Let's get another log on the fire, guys. Okay. The fire looks pretty awesome. All right, so I'm going to jump into a bunch of questions about infusions that I have saved up in my infusion folder. So the first one comes from Julian Martin. So Julian Martin writes in, Dr. B, how many infusions of alemtuzumab can you have? Is 4 the max amount over a lifetime, or do you just keep receiving it? That's a great question. We now have 8 years of long-term follow-up with regards to the phase 3 clinical trials. And in those 8 years, we have patients that have received the standard 2 doses, 3, 4, and 5 doses. I'm not familiar with the 6th dose given. I'll tell you that in my own clinical practice, we've given most patients 2 doses, and a handful have received 3. I have yet to administer a 4th round in clinical practice, mostly because of the timing. Now, that's not really the question. I'm not aware of a lifetime maximum dose for Lemtrada. However, if I treated a patient with 3 or maybe 4 rounds and it wasn't working, I think that I might leave Lemtrada. If I'm not getting what I want out of 3 or maybe 4 rounds, I think really at that point we would have to critically look at our goals of Lemtrada. And I'm not aware of lots of people going on in extended dosing, keeping in mind that the drug hasn't been out long enough for us to gain a large group of experience. So I think over the next several years, that'll play itself out. So this next question is the same person, Julian Martin, also writes another question about Lemtrada. What's your thoughts, Dr. B, on the FDA pulling Lemtrada? I'm due for round 2 in 2 weeks, feeling nervous. Well, Julian, the FDA did not pull Lemtrada. I'm not sure, maybe there's some confusion. The EMA, which is the European version of the FDA, is currently reviewing the safety of Lemtrada. They're going to do their equivalent of a label update. That's due in July. And they said, hey, because we see some safety signals, don't use Lemtrada first line. This is Europe. Okay, because in Europe, they're allowed to use it first line for aggressive disease, but the European Union has put a hold on that while they analyze the data. So the FDA has not pulled Lemtrada, and I think that all the thoughts that go into preparing for a Lemtrada infusion still apply. So this next question is from Anne Walsh from Ireland. Man, I love Ireland. It's an amazing, enchanted place. I visited Ireland 3 times. All 3 times, I swear that I always want to go back. I hallucinate about having a home to retire there. It is some of the most beautiful country I've ever seen. I find the Irish to be amazingly warm and friendly. I love pub culture, and I love the green. I don't know how you guys pull off such deep green. Sorry, I diverged, but I really love where you come from. So Anne writes, on Tysabri for 13 years, did very well. Think I am in a relapse. Question, can I take steroids with Tysabri? I've just turned JC virus positive, low titer. Love your channel. Well, Anne, thank you very much. Yes, you can take steroids with Tysabri. Tysabri was originally called Antigrin. When it first was being studied, they called it Antigrin. And the very first trial that I'm aware of in the MS space was to treat attacks, where when someone had an MS attack, they gave them Antigrin, now what we call Tysabri, and steroids. They were given together. Now, it didn't work to help attacks, but it was completely safe. And yes, you can give Tysabri. Now, some people ask this question because they're concerned about stacking immunosuppression, Tysabri plus steroids. And I'll remind everyone that 5 days of high-dose steroids does not massively suppress the immune system in the same fashion, in the same fashion that chronic steroids suppresses the immune system. So if you took steroids daily, every day, all the time, for months, that would be suppressing your immune response, and that plus Tysabri would be a no-no. But taking 5 days for an attack, that's not concerning. The chickens are running around in their coop over there. They're having a little chicken fight. This happens sometimes. The next question is from Jody Cypelt. So Jody Seibelt, or Seipelt. How long does it take Ocrevus to start having an effect? That's a good question. When you look at the clinical trials data, we see that at 6 months, as compared to Rebif, we shut down relapses by about 40%, and we decrease the relative risk of disability by 46%. That's at 6 months. We see that the GAD lesions are shut down like 91 or 95% at 6 months. T2 lesions take about a year. So the effect on T2 takes a little bit longer than contrast lesions and the relapse reduction. My point here is you can't take Ocra, wait 3 or 6 months and be like, okay, it's fully working, because it can take a little bit longer than that. Powering through these questions, the next one comes from April Swinehart. Hey, April. I'm on Ocrevus, and I'm noticing my toes are moving more for the first time in the morning. Is this a possible improvement due to Ocrevus? Will it continue? So when we look at the Ocrevus data, the OPERA trials, we see that 20% of patients, 1 in 5 patients, noted confirmed disability improvement, where they seemingly regained a neurological function at least for a period of 3 months. So is it possible? Yes, it's possible. Will it be sustained? We don't know. The definition of CDI is not that it stays, that you permanently gain a function. It's that we see a gain in function for at least a period of 3 months. All that aside, April, congratulations. That's freaking awesome. And I hope that you maintain that function. I think it's really, really exciting, and I'm happy for you. How are we doing with the fire back there? Pretty good fire. I hope you guys like my outdoor fireplace. This is my favorite room in my house now. I love sitting outside here in the mornings and after work and in the evenings. It's really relaxing. And it's just a really fun place to spend time. I love a wood fire. So this next question about Ocrevus comes from El Prieto, Prieto, El Prieto. I think that's how you pronounce that. Good morning. Well, good morning. Just tuned in. Quick thoughts about Ocrevus. Well, I've been discussing Ocrevus. I also have a playlist on my channel where I have many, many videos on Ocrevus. So El Prieto, if you would like some more information, just go to my playlist and you can watch all my videos on Ocrevus. Now, this next question is from Jody Seipelt, who asks, can we spread out Ocrevus infusions during remission status? And the answer is no. That's not a good idea. Don't do that. We can't do that because the way Ocrevus works is it kills adult B cells. And for the most part, it takes about 6 months for those to come back. So if you spaced out the infusion, say every 9 months, there would be a period of about 3 months when you were unprotected. So if you have achieved degree of disease stability on Ocrevus, I would submit maybe Ocrevus is working and I wouldn't want to spread it out. The caveat is there's some evolving literature looking at people with a large BMI, so bigger humans, and it looks like they may need dosing more frequently, and maybe little tiny humans might need a dose less frequently, but that's still being worked out. That's not gospel. And my message to most people would be, hey, let's do every 6 months so we can keep you safe. Great question. Thank you for asking it. So this next question comes from Terry Joe. Good morning, Terry Joe. So Terry Joe writes in, there's Ohio Health, and that's where I work. And if you guys ever wanted to know more about Ohio Health's MS Center, it's a place I'm really proud of. On my YouTube channel, up in the upper right-hand corner, there are some buttons, and you can click a button that'll teleport you to the Ohio Health MS Center website, where you can read about all 4 of us doctors and the 4 nurse practitioners and the wonderful things that we do. Just FYI. But they're referencing where I work at Ohio Health. And Terry Jo says, does Ohio Health allow Ocrevus patients to pre-medicate with Benadryl and Tylenol 30 minutes before the appointment? Well, Terry Jo, we take care of that for you. When you come in to be infused, there's an hour of pre-medications given before we start the infusion. And during that hour, we're giving you a low dose of steroids, about 125 milligrams of IV Solumedrol. We're giving Tylenol. We're giving Benadryl. So we're taking care of all that for you. We don't want you to pre-treat at home because we're going to give it to you when you're there. We're also going to monitor you, and we redose those medicines if it's needed. This next question is from Jennifer Crookshank. Jennifer writes in, if a patient relapses on Ocrevus, would you change their treatment? And the way I would think about this is, anytime you have breakthrough disease on any drug, there needs to be a discussion about whether we need to escalate or change therapy. One second. Sorry. So if you have breakthrough disease, whether that be an attack or whether that be a new spot on MRI, then I think that we need to have a conversation about, do we need to escalate? It doesn't mean you're going to escalate. It just means you need to be thinking about it. And the reason that it's a discussion is, it depends, for example, when you had an attack. If you started Ocrevus and the next month you had an attack, it's too soon to blame Ocrevus. If you had 5 attacks a year, hypothetically, and now you only have 1 attack a year, that's different than if you've gone for years without an attack and then you have one. So there are a lot of human variables that we need to consider, no question about that. But the take home for this question, in my mind, is if you have breakthrough disease, we have to discuss whether or not we would escalate. It doesn't mean we have to, it means we need to talk about it. I want to thank Chuck. Chuck O is a moderator on the channel, and he is watching and moderating. And so thank you, Chuck. So this is a channel of love. We're positive on this channel, and we don't really have time or space for negativity. And so if Chuck identifies sort of a negative Nancy kind of comment, he's probably going to delete that comment. And so I really appreciate you as a moderator, Chuck. Thank you. This next question comes from RLE Fevers 0485. What is the Tysabri rebound effect? So Tysabri is a really highly effective MS medicine, and I have videos on my channel that talk about how Tysabri works. So if you want to hear specifics about that, please check that out. But essentially, it creates the Great Wall of China. It creates a barrier. So all the naughty white blood cells are in the bloodstream over here, and then there's a barrier, and then they want to access the brain. And if those cells get over into the brain, they're going to attack it. So when you create the Great Wall of China, you disallow those cells from getting through. That's how Tysabri works. But if you if you remove the barrier, if you remove Tysabri, those cells can come back in the brain. And sometimes they kind of bum rush in, and you can see a rebound. Rebound is defined as higher clinical activity than before you started on Tysabri. And so sometimes we can see, and it's not common, but it can happen, a very severe attack. And when you get an MRI, their head really lights up. They have lots and lots of lesions. It's very scary. So a rebound is something that we see with Tysabri when someone stops it and then nothing else is done. A percentage of those patients are going to have a really, really bad outcome. And so we have to be very planful. In fact, I made a video that will be published tomorrow morning at 6 a.m. Eastern Standard Time called Drug Washouts. It's about drug washouts. And I talk about how we navigate Tysabri and how when we stop Tysabri, we can't just completely stop it. We have to have a plan for what we do next. So let's take a look at some more general disease-modifying therapy questions. So this is a question from Beverly Swingle. If relapses still occur on Rituxan, but I can't take Tysabri, do you move to a lower DMT? How many relapses does it take to consider changing a DMT? So 2 questions. So the first question is about what happens if you have breakthrough on Rituxan. and you can't take Tysabri. Well, in my mind, there are other options. One option would be Limtrada. They asked the question, could you downgrade? And that's not generally our goal, but we take care of people, Beverly, in the real world. And in the real world, we have to make do with the options that we have. So the way that I approach this, when someone has a breakthrough on any drug, is we hit pause, and then we list all the drugs that they haven't yet been exposed to. So if they haven't been on 10 drugs, we write those drugs up, and then we start to cross ones off that don't make sense. And I think that's an exercise that we have to go through every time that we have breakthrough disease. Now, how many relapses does it take to change drug? That depends on you and your doctor. There are many patients where one attack and we move on. There are some patients who one attack and we put the drug on warning, and we say, any more activities, then we're going to upgrade, but we're not ready to cut bait just yet. That's a very individualized group decision, which is different for each person in each situation. So this question comes from Huda. Huda asks, hello, Dr. B from Saudi Arabia. Well, hello, Huda from Saudi Arabia. Can MS or the DMT cause respiratory problems, shortness of breath? Really appreciate your efforts with us here. Many thanks. Well, Huda, you're welcome. So MS generally doesn't cause shortness of breath. Rarely it can. When you have spinal cord damage, sometimes people feel like they can't take a big enough breath. I've seen that a handful of times. Very, very uncommon, normally associated with spinal cord lesions. There is one class of disease-modifying therapy, and that's Jelenia and Mazent, the S1P1 receptors. Rarely they can impact breathing and shortness of breath. And so if you start one of those medicines and then you have some shortness of breath, you want to bring that to the provider's attention. Also, if you have asthma or COPD, when you start those medicines, make sure that the clinician knows that so that they can be on the lookout for it. So this question is from Ellie Smithy. And Ellie writes in, random question, is it worth wearing a face mask to protect ourselves from flu, etc.? And I don't think so. I don't recommend that just as a general rule, because you have MS, you walk around with a face mask. I also don't think that there's a given therapy that mandates that you wear a face mask. Individuals may have situations where they have a really low white count where it is discussed whether they would take precautions like that. But I really think that's an individual thing. There may be certain situations with certain drugs where for a period of time you're immunosuppressed. And during those times, there may be additional precautions. But I think as a general comment or rule, I don't think that MS patients need to wear masks. This next question is from David Binford. And David writes, would it be okay to take an immune booster supplement, or would that be a bad thing? And the answer is that would be a bad thing. So people with MS have an overly active immune response. Your immune system is overly active. It's so overly active, it's actually attacking yourself. So if you go to a health food store and they sell you an immune booster, the good news is it probably doesn't work. Most of those immune boosters almost all of them have not been studied by the FDA. And fortunately, it probably doesn't do anything to legitimately boost your immune system. But if it did, that would be the wrong direction. And I certainly would not recommend taking an immune booster. So Brenda, that's a fun screen name, Brenda, writes in a question. What do you think about pregnancy and MS? How long to stay off the medication? Brenda, that's an awesome question. I'm going to not answer the question and instead direct you to a video that I did where I take a really deep dive talking about MS and pregnancy. And I talk about coming on medicines, coming off medicines, planning pregnancy, the stages of pregnancy, what happens after delivery. It's a really, really big and important topic. And so, Brenda, I'm going to encourage you to go to my channel and search for a video on pregnancy. I think I did a decent job of summarizing it in that video, and it's a really important topic. So Anonymous Girl writes in, Dr. Boster, have you ever had a patient whose MS has gone into remission? Well, many of you know the definition of remission that I use is the oncology definition, which is 5 years with no disease activity in the absence of therapy. So I've had many, many patients that are on a therapy and have 5 years of quiet. I see that a lot, but I don't consider that remission based on that definition. And the therapies that we have that are discontinuous, like Limtrada, Cladribine, Mitoxantrone, those would be the therapies where you might see remission. And Limtrada hasn't been out long enough, really, where we've seen 5 years of quiet. In a post-marketing setting, I have people that are 4 years plus. They're approaching that threshold. And so I think there's a high likelihood that several people in our clinic, as they crest their 5th year, will meet that definition. All right, so I got through all of the disease-modifying therapy questions. There's 100 people online, and there's 55 thumbs up, and that made me feel good. If you guys are just jumping online, I went online this morning so that I could knock out some questions that I haven't gotten to. I'm not going to be answering your live questions right now. I will, obviously, as I always do, go back through the post and I'll write down the questions that I didn't get to, and that's how I populate these folders. So let me do another bucket of questions here. We'll just do this a little bit longer today. Here's a question about symptoms, and this question comes from SoCal Lynn, aka L Holly. So SoCal Lynn is also known as L Holly. So hello, Lynn Holly. The question is, please discuss MS and dental health. I've been having horizontal cracks appearing since last year, since starting Openness. So MS doesn't directly impact dental health. Taking things like high-dose steroids can impact dental health, but MS, the disease, doesn't impact your dentition. People with MS sometimes have to go see the neurologist a lot, and sometimes people with MS are so busy seeing the neurologist they don't make it to the dentist. I've seen that in my clinic. Dental health is really, really important, however, and you should see the dentist, because if you have dental caries, though the bacteria in your mouth can seed your gums and seed the blood and can cause infections, and that can make you have pseudo-exacerbations. So dental health is really important. I'm not aware of an association of Ocrevus and causing cracks in your teeth. I haven't heard that or seen that or read about it, but it doesn't mean it's not happening. And I would, at bare minimum, go talk to your dentist. All of us, myself included, should see the dentist on a regular basis. Next question is from Amy. It's Arnie. I'm sorry. Arnie Johnson. I'm butchering names this morning. The name is Arnie Johansson. What do you feel about antidepressants for MS patients? Well, Arnie, I have many videos on this channel about depression. People with MS are twice as likely to be depressed, and antidepressants work really well. So I have a very, very low threshold to discuss treating depression with people with MS, and I have a very low threshold to recommend taking an antidepressant. Antidepressants are very, very effective. It's not the only way that we take care of depression. I have a video on this channel, which I think I entitled 20 Tips to Tackle Depression. One of those 20 tips is taking the medicine. 19 of the other tips are obviously other things. So check out that video. The next question comes from Stacy Lee. Good morning from Cincinnati. Cincinnati is a great town. I did medical school at University of Cincinnati. I loved living there. It's a really cool town to be a young person in. Can you address heat humidity and why it makes MS symptoms worse? Well, Stacy Lee, I have an entire playlist on my channel, which talks about temperature-related symptoms in MS. And so I would encourage you to check out that playlist. It's called Temperature-Related Symptoms in MS, and there's 6, 7, 8 videos there that really focus on temperature. And on Friday's live stream, the live stream I just did 2 days ago, in the very beginning of the live stream, I talk about that at some length. So I'm not going to delve into it right now, but I'll encourage you to check that out, and I think you'll find your question answered. I'm going to transition on camera from coffee to water. As many of you know, I always challenge you to drink more water. So I call this the MS Water Challenge. When I drink, you drink. So let's fire it up. Good stuff. All right, this next question is about melatonin. So El Prito writes in again. It says, good morning, Dr. Boster. My question is, melatonin is no longer working for me the way it used to. Any advice on the milligrams or the frequency of using it? And of course, El Prito, I can't answer the question for you. I can't give you direct medical advice on the interwebs. I can tell you that melatonin is a naturally occurring substance. It's the way that your body tells you it's time to go night-night. And you can take supplemental melatonin. It's very hard to take too much melatonin. And I would tell you that with any sleep aid, if you use it consistently every night, sometimes it can wear off. Just checking on the fire. It's going pretty well. And so if you're taking a sleep aid and you're finding that it's not helpful, you may have acclimated to it. And you may need to take a break from that sleep aid for quite some time before revisiting it. I have several videos on the channel where I talk about sleep and sleep hygiene. And so while you're fighting through trying to get melatonin to work again, check out my video on sleep hygiene, where I talk about several behavioral techniques that can really assist in your ability to sleep well through the night. So here's a question that I got from, I'm going to not say this name right, Kaitar, Kaitar? J''KHAAR. I'm just going to say Kaitar. So if I'm saying your name wrong, I'm sorry. So still hoping for anyone to jump in. How can you tell the difference between ocular migraine and optic neuritis? That's a good question. And there is a way of sorting it out. Historically, a ocular migraine typically has positive symptoms. So there's a symptom called a scintillating scotoma, which is where you see bright, shiny, kind of sparkly lights. And it's sort of superimposed on your visual field. And that's a hallmark of a visual aura or a visual migraine. Typically, people see shiny, scintillating lights, and then later they have a headache. So that's the classic description of an ocular migraine. Optic neuritis may or may not cause head pain, but it more commonly causes eye pain with eye movement. And what people see isn't shiny, scintillating scotoma. They see loss. So they have negative symptoms. They lose part of their visual field. So really, taking a careful history, normally we can sort out one from the other. There's also visual findings that we might see when looking in the back of the eye that we see with optic neuritis that we don't see with visual migraine. So with an optic neuritis, we can see a swollen disc or a pale disc, and with an ocular migraine, normally we can't. So good standard neurology is the way we sort that out. Next question comes from Mark Carfang. So Mark says, what do you think about MS Gym? So MS Gym is run by a guy named Trevor. It's based out of Facebook, and people can pay money. I think it's like $1 a day to have access to a lot of his workout videos. And I'll tell you that MS Gym doesn't appear to be based on the same scientific principles that neurophysical therapy is. Sometimes the rationale for the exercises is not medically based. But anecdotally, many patients love and benefit from MS Gym. So I'm always looking for ways for people to exercise with MS. And not everyone can make it to the commercial gym or can make it to the physical therapy suite. So the fact that for not very much money a day, you can have access to these MS Gym videos and do them at home, I think is really cool. So overall, I think that it's probably a benefit. I think that it's one opportunity to exercise, but some of the rationale behind the exercises, like the explanation of what's happening, are not scientifically based, which doesn't make it invalid, just means it's not based on science. So overall, I would give MS Gyms a thumbs up as an opportunity to exercise amongst many other options. That's just my opinion. So this next question is from Karen Munley. Karen, I hope you're doing well. You have some suggestions on how much water to drink and how to space it out. Would you repeat that information? Thank you. So Karen, I'm happy to repeat that information. And so, in trying to get you to drink more water, maybe one way to approach it is to drink 1 glass of water with each of the 3 meals, breakfast, lunch, and dinner. And then drink 1 glass of water between breakfast and lunch, and 1 glass of water between lunch and dinner. That would give you 5 glasses of water, and that would really get the ball rolling. So that's a great way to do it. The other advantage to that is that it helps stack the water in the first half of the day, and that way you're not making lots of urine when you're headed to bed at night. So this next question was asked on Friday. Alistair and Andrea Downey writes, yeah, please, if too much pain for exercise. And what they're really getting at was, what do you do if you're supposed to exercise but it hurts to move? And two ways of trying to approach that. One is exercise in the water. Pain tends to be decreased. Our leverages are better. We weigh less. And so sometimes exercising in water helps a lot. Also, I would work with a neurophysical therapist because they're sensitive to the fact that you're in pain, and they can alter the exercises to help you. This next question comes from Verna. And Verna writes, question from Nova Scotia. Well, hello, Verna from Nova Scotia. How do we keep a positive outlook when our best versions of ourselves isn't enough? And, I'm going to throw that question out to this community. Verna is asking all of us a really important question. How do you maintain a positive outlook despite having this chronic condition? And so I'm going to ask the community to write comments about how you do that. Share with Verna and with all of us the techniques and tricks and tips that you use to maintain a positive outlook. I would love to hear from you guys. This next question comes from Amanda Anderson. It was from the live stream just this past Friday, 2 days ago. Question, please let us know if migraines and MS are related in any way. And I'll tell you that people with MS are more likely to experience headaches than the general population. So they are related. And that probably has to do with cortical inflammation. Fortunately, we can treat migraines the way that we treat migraines. But yes, sometimes nature is a little too generous, and you can have an increased risk of migraines in the setting of MS. And the last question in this folder is, again, from live stream on Friday, where people asked about doing a water fast. So I don't recommend a water fast without talking to your doctor. A water fast is a pretty extreme thing, and we have to be worried about energy expenditure and having enough calories and energy to get through your day. And so I would not recommend doing a water fast unless you've talked to your doctor. Two more questions here, talking about neuropathy. And so this is from Cheryl Palmer, who says, can you have peripheral neuropathy and MS at the same time? And the answer is yes. So peripheral neuropathy is doctor talk for damage to the nerves, the peripheral nerves. We generally separate the central nervous system from the peripheral nervous system. Central nervous system is what I study, brain, optic nerve, spinal cord. And we sort of separate that from the nerve roots and the nerves coming out in the muscles. So when you have damage to the nerves, that's a peripheral neuropathy. And you can have MS and a peripheral neuropathy. It's not the same disease pathology. It's two separate things. And yet sometimes nature is a little too generous. And in fact, you can have both. Now, the good news is the symptomatic medicines to treat neuropathic pain work for both. And so that's good. You don't have to sort out one from the other to be successfully treated. All right. I got through that folder. That makes me feel good. I've been online now for 42 minutes. I really enjoy that I got a chance to kind of get caught up on some questions. Of course, I have many more still in other folders, which I'll get to another day. I'm going to wrap up now and go inside and wake the family and kick this Sunday off. But I want to say thank you to you guys. There's 104 of you that jumped online with me. That warms my heart. There's been 75 thumbs up, so I'm going to interpret that as you've enjoyed what you've seen today. As always, thank you for learning about MS with me. And until my next video or my next live stream, this is Aaron Boster saying take care.